Hello, everybody. Welcome back. We are back to our webinar. I'm Daniel Ciampi. I'm talking from São Paulo, Brazil. And I have Brian Wellet with me, co-chairing this third part of our webinar. Right now, we're going to have three excellent speakers coming to the podium. First one is Xavier Moisset, who will be talking on COVID-19 and headaches from epidemiology to management. Xavier is a French neurologist and clinical researcher. His mentors are Radouane Dalel, Ndph Clavlou, and Didier Vassira, and Professor Nadine Attal. He's currently full professor of neurology in Clermont-Ferrand University Hospital. He's a member of Radouane Dalel's lab and has a particular interest for headaches, migraine, cluster headaches, pathophysiology, and treatment. He's also interested in neuropathic pain, neuromodulation, especially by rTMS, and the link between pain and inflammatory diseases, such as multiple sclerosis.
Our second talk is entitled The Long COVID and Pain, the Asian Perspective. And I hope I don't do you disservice, Professor, but the speaker is AKM Akhtaruzzaman. How bad did I do?
Yes, Akhtaruzzaman.
Thank you so much. It's a tough one, but he is the chairman of the Department of Anesthesia, Analgesia, and Intensive Care Medicine at Bandhu Sheikh Mujib Medical University. He used to manage pain conservatively, but when required to do interventions, he will. He is one of the founders of the Dhaka Pain Management Center, which is designed to be an effective pain relief destination to patients suffering from acute and chronic pain. Besides his training and expertise of working in Bangladesh, he has worked with some premium medical facilities in India, Japan, as a pain specialist. He has more than 100 publications in different peer-reviewed national and international journals. He has supervised around 40 academic theses for MD residents, including PhD theses. And he has vast experience in research works related to medical education, pain, COVID, and new devices. He is the current president of the South Asian Regional Pain Society, SARPS, a federation of the IASP. Our third speaker will be presenting a talk entitled Patient-Led Research on Long COVID, and this is Lisa Mccorkle. She is a long COVID patient herself and is the co-founder, team lead, and researcher with the Patient-Led Research Collaborative. She is also currently a CalFresh policy analyst at the California Department of Social Services. Her past projects involved analyzing data and developing policy recommendations in the fields of digital equity, economic justice, housing, and health equity. She's an author of several articles on labor and employment issues and a study on stable scheduling for hourly retail workers. She received her master's in public policy from the University of California, Berkeley, and a Bachelor of Arts in Political Science from the University of California, Los Angeles. We hope that you enjoy the presentation.
Good afternoon. I am Xavier Moisset. I am a neurologist working in France and particularly interested in headaches. The goal of this short presentation is to give you an overview of current data concerning headaches prevalence, characteristics, pathophysiology, and management. Before starting, you can see my conflict of interest statement. First of all, I want to show you that it is very difficult to look for established facts during this pandemic. As you all know, the pandemic started less than 2 years ago, but I want to show you that many articles have been published and that it is impossible to perform an exhaustive review of the literature. Headache is a word that is often used in medical articles. As you can see, a PubMed search for headache allows to find a bit more than 100,000 articles published during the last 50 years. But if you search for COVID-19, you have more than 160,000 articles. Even if you limit the search to the articles dealing with both COVID-19 and headaches, you still have more than 1,200 articles. Thus, the presentation won't be exhaustive, and I apologize if I have missed an important study. I have chosen a meta-analysis focusing on 54 articles published during the first semester of the pandemic. The pooled prevalence of headaches during COVID-19 was around 15%. Most of the articles were coming from Asia and particularly China. And as you can see on the figure, there are some outliers coming from elsewhere in the world. You can see that the prevalence was much higher in Europe and America. Thus, we can wonder if this is the case for other headaches. Data coming from the global burden of disease study help to answer this question. As clearly shown on this map, migraine prevalence is lower in China compared to all other countries in the world. And another point that can explain headaches prevalence variation is age and sex. Indeed, headaches and migraine are more prevalent in middle-aged women. Thus, it is important to take age, gender, and geographical area into account when speaking about headaches during the COVID-19 pandemic. In this large study conducted in Europe, with a majority of middle-aged women, headache prevalence was 70%. And as you can see, on the last column, the prevalence was lower among older people. Another European study of smaller size, but concerning consecutive patients, found a prevalence of 59% for new onset headaches during the infection. This was one of the first studies showing that headaches were neither associated with disease severity. You can see that there are not more hospitalization in general or in intensive care units in patients with headaches, and that was not associated with symptoms such as anosmia or ageusia. 1 month after the resolutions of fever and dyspnea, around 4% of patients were still presenting with unusual headaches. Thus, during the first semester of the pandemic, there was enough evidence for high prevalence of headaches among European and American patients, whereas the prevalence was not so high among Chinese patients. But we can ask if it is really surprising during a viral infection to present with headaches. And we've got data to answer this question. If we compare with data obtained during influenza virus infection, we can see in this large study conducted in Europe recently, involving nearly 6,000 people, that 63% of the patients were presenting with headaches. Thus, headaches prevalence seems quite similar to what can be seen in other viral infection. To go a bit further, let's speak about headache characteristics. In this series of consecutive patients from Europe, recruited in an emergency room, 75% were presenting with headaches. Headache intensity was moderate or severe in 75% of the patients. Headaches were frontal or holocranial for the vast majority of the patient, and pain was of pressing quality for 70% of the patients. Moreover, it is important to note that pain was constant for half of the patients. And on the last column, you can see that simple acute treatment were effective in the majority of the patients. In the same study, you can see that 25% of the headaches were described as migraine-like headaches. COVID-19 symptoms duration was somewhat shorter among headache sufferers. Headaches were still present 6 weeks after symptoms onset in a very significant proportion of these patients. Indeed, you can see that 38% were still presenting headaches 6 weeks after the first symptoms. Among these patients with persistent headaches, headache was often the first symptom of COVID-19. So if you start with headaches, your infection, you have a higher risk to present headache for a longer time, even if the infection is not more severe than in patients without headache. In this study, also conducted in Europe on a very large sample of patients with COVID-19 that were interviewed by 18 different physicians at least 1 month after symptom onset, the prevalence was very much lower, with only 24%. And there is no obvious reason for such difference, as the study was conducted at the same period of time, in the same geographical area, and with a comparable methodology. However, the description of the whole population is not given. Thus, it is not possible to say if some demographic characteristics can explain at least one part of this low prevalence. Among patients with headaches, there are mostly middle-aged women, and headaches were frequently the first symptom. This study confirms the pain characteristic we already see. Pain is usually frontal and bilateral, of a pressing quality. Photophobia and phonophobia are present in 1/3 of the patients. The median duration of pain was 7 days, but a significant proportion of patients present with persistent headaches 1 month later. You can see 13% in the study. And again, that was not more dangerous to have headache during this infection. There was not more frequent hospitalization among patients with headaches. If we try to classify those headaches, I prefer to recall the International Classification of Headache Disorders. The most obvious code to classify such headaches would be the 9 headache attributed to infection. And more precisely, we can say acute headache attributed to systemic viral infection. But some other codes are possible depending on the timing of headache's appearance and other findings. It can be simply an exacerbation of a previous primary headache. It can also possibly be a primary cough headache or a headache induced by hypoxia or hypercapnia. We will discuss later of other secondary headaches and about potential new daily persistent headaches. In this study conducted also in Europe, in Spain, hospitalized COVID-19 patients were evaluated again 7 months after initial symptoms and compared to COVID-19 patients with the same age and sex that were matched as controls. And you can see that patients with initial headaches were more likely to present with tension type like headaches 7 months later. So this persistent headache, new daily persistent headache, how can we define them, and is that unique to coronavirus? First, what is a new daily persistent headache? According to the definition, it is a persistent headache with a clearly remembered onset, present for more than 3 months. Thus, once infection is over, persistent headaches can fulfill this definition. And are new daily persistent headache something new? The response is clearly no. The first descriptions were given after the 1890 viral pandemic known as the Russian or Asiatic flu. After this pandemic, there was extensive documentation about the neurologic sequelae that presented months to years after the pandemic ended. That was called neurasthenia, and many patients were reported persistent headache in this post-infection syndrome. So this is not unusual with any virus to have persistent headaches. Concerning the pathophysiology of these headaches, the exact pathophysiology is unknown and several factors can explain these headaches. Acute headaches can be due to the cytokine release syndrome that exists at the beginning of the infection. And several studies have shown a correlation between cytokine level and headaches. It has been shown on MRI that some patients have meningeal inflammation, and this is probably the case in some patients with headaches, even if we cannot do MRI to every patient with headaches. But several other causes can induce headaches. That is the case for vascular syndromes that are well described, such as ischemic or hemorrhagic strokes, cerebral sinus and venous thrombosis, Press syndrome, but that's also the case in case of inflammatory CNS syndromes, such as encephalitis, meningoencephalitis, ADEM, or associated with intracranial hypertension. In these cases, they are really severe and patients were not presenting with isolated headaches. But if the patient has very severe headaches that are not relieved by classical analgesics, it can be useful to look for these syndromes, either vascular or inflammatory in specific cases. To end with, I will just say a few words concerning treatments. For the acute phase, both acetaminophen and NSAIDs can be used. They are sufficient in most cases to control headache pain, and NSAIDs can be used without increasing the risk of mortality in the absence of concomitant bacterial infection. The problem for the treatment is much more difficult in the case of persistent headaches. It is suggested to treat new daily persistent headache according to the predominant headache phenotype. For tension-type headache, it is suggested to use non-pharmacological approaches such as biofeedback, relaxation, or cognitive behavioral therapy. And for pharmacological treatments, we can use amitriptyline, mirtazapine, or venlafaxine. For migraine-like headaches, first-line treatments are topiramate, propranolol, and amitriptyline. For patients who do not respond to common prophylactic drugs, ketamine infusion, onabotulinum toxin type A, IV lidocaine or IV methylprednisolone, and nerve blockade are possible treatment options. But for these new daily persistent headaches, even aggressive treatment is usually ineffective. And time can be a useful thing to reduce pain progressively in months or years. If you've got any questions, please feel free to ask.
Gentlemen, good morning, good evening, according to the time zone of the world. My today's presentation, long COVID and pain, the Asian perspectives. I don't have any conflict of interest on my presentations. This is my university hospitals. It has 1,800 beds, 56 departments, and more than 500 faculties. My pain medicine unit, it is a OPD service and Kusaka Pain Clinic interventional services. Before the COVID, we usually do in the pain clinics, but during the COVID, we reallocated to the COVID-dedicated intensive care unit from all of my staffs and faculties. I have set 3 learning objectives: a spectrum of post-COVID conditions, Asian perspective, and understanding of post-COVID pain. And we all know that after the December 2019, we have lost at least 222 million people are infected and lost about 4.6 million populations. The disease presentation and disease spectrum is different among the demographic and geographical populations. It starts from the attention and policies, and all these things that causes the medical facilities, these are the overwhelmed by the COVID-19 pandemic, which leads to traveling restriction and nationwide lockdown. It causes a lot of people in the jobless and burden to the economy. At the time, we reallocate our health facilities and resources. And sometimes it closes the non-urgent services, including the pain service. The recent article published in Best Practice and Research in Clinical Anesthesia, they rightly said that in the developed countries, they prioritize and allocate the resources. Not only that, they maintain the strict isolation and quarantine policy, as well as testing and tracing. They have enhanced their healthcare facilities. They provide the healthcare facilities using the digital. And at that, using these conditions, they decrease the mortality and morbidity, that reorganize the healthcare settings and starts the non-emergent services like the pain clinics. They have also developed guidelines to assess the post-COVID scenario. But the scenario in the South Asia, as well as in the Asian countries, because of their financial incapabilities, we can't maintain the strict isolation and quarantine policy. Fail to vaccinate the people at a pace with the developed countries. The appearance of the new variant, Delta variant, and other like the Mu, and we don't know what are the next. At the cost, they have increased the case and increased the mortality and morbidity. They break down the healthcare facilities, and we mainly focus on the acute outcome, not in the non-emergency services. Can we focus in the previous epidemics, starting from the 2012, that is the Middle East respiratory virus, to the avian influenza, that is in 2013-19. Though the chikungunya is started in the Africa and prevalent in Southeast and South Asia, the COVID-19 started in the Asia and traveled to the whole world and territories of the all countries and territories. So we have searched that post-viral syndrome, the relationship with the chronic COVID syndrome. And you know that the Journal of General Practice, that the post-viral review in the year 1986-7. After that, we encountered the post-viral fatigue syndrome and rightly put it in the British Medical Bulletin in 1991. And later parts, the post-traumatic stress disorders after the SARS. The disease spectrum of the viral is almost same. The acute viral illness, sometimes it causes the fever, headache, myalgia, fatigue, loss of appetite, and organ-specific symptoms. And the post-viral symptoms, they're almost pain, fatigue, and memory difficulties is the conditions. But in the post-chikungunya, the joint pain and neuropathic pain and chronic orthostatic pain is the predominant. During the post-COVID syndrome, published in the March 2022, they have rightly said that the post-COVID syndrome is starting from the subacute or ongoing COVID-19 and post-COVID area. They mostly starting from the fatigue, decline in the quality of life, and joint and muscular weakness. Not only that, sometimes it can cause the post-traumatic stress disorder, even in the chronic kidney disease and disease of the myocardium. But we have failed to make it the consensus definition on the post-COVID syndrome. The published article in the 2021 in the International Journal of Environmental Research and Public Health, they have potentially divided the COVID scenario into four: the acute scenario, post-acute, long COVID, and persistent post-COVID, that lasting after the 24 weeks. In the recent article published in Anesthesia, they have formed a guideline from the Association of Anesthetists, Federation of Surgical Specialties, the Royal College of Anesthetists, and the Royal College of Surgeons of England. They have almost phased out the COVID-19 into the acute phase, ongoing symptoms, post-COVID syndrome, long COVID, and resolve states. They have made it in the 5 states. There is another consensus is that the international experts under the Shanatana and her team, they have rightly pointed out the post-COVID pain management. It is starting from the using the telemedicine, using the biopsychological management of pain, and they focus on the using the pharmacological medications, that is prescribing of the opioids, NSAIDs, and the steroids. Though there is no consensus on using the steroids in the early stage, it might cause the viremia. What is going on in the Asia? The studies in Asia, this is Malaysia, they have the 66% patients have an experience with post-COVID symptoms. In the Japanese Health Ministry, they have also pointed out that after the COVID, the long COVID syndrome may continue after the 6 months. In Bangladesh, India, and China, the almost the same scenario. In China, 76% population is suffering from the post-COVID syndrome. This is the 3 main areas: that persistent fatigue, shortness of breath, and sleep disturbance. This almost same scenario in the whole world. In UK, the fatigue is 68%. But in US, shortness of breath is around 43%. In UK, sleep disturbance is 57%. What about the COVID pain? Mainly in the joint pain, chest pain, headache, and myalgia. In US, in joint pain is 27%, but in Bangladesh is 1% only. In myalgia, is in US it is 6%, and Iran is 8%. As we all know that the post-COVID pain and the spectrum of the pain is a 3 scenario we can divide. The pre-COVID chronic pain continuation, that is mostly in the chronic cancer pain, chronic low back pain, and chronic rheumatological pain. The second scenario is that worsening of the chronic pain after the COVID because of the disturbance and disruptions of the services. And not in the least, the newly acquired pain that turn into the chronicity. That's mostly occurs during the acute phase and hospitalized populations. So there is a cycle of sufferings of pain. It starts with the rehabilitation of changes and ends in the neurological insult. And in the ICU, they have sorts of pain because we are using a lot of procedures, even proning, and risks of sepsis. So all are related to the post-COVID pain sufferings. So in Bangladesh, we did research on the long COVID and long hauler. This is the Mr. Asaduzzaman, is a sufferer of long COVID problem. Though he has no pain before the COVID, and after that, he has significant post-COVID functional score, and he is suffering from the persistent fatigue, shortness of breath, memory difficulties, inability to concentrate. This lady, she's suffering from pain in the pre-COVID era, the low back pain only, and this her BAS is around 4, but after the COVID, it is the 7 to 4, and but most that it interferes her daily life. It is around 3. We have started a academic research in my departments. This is the MD thesis in the post-COVID scenario. And so far data collected, so pain and disabilities increase. And post-COVID functional status score is around 2. But are we able to look after this post-COVID pain and in our healthcare services? In the pre-COVID era, we have a disease burden. Is 1 in every 5 patients came to seek the medical care because of the pain. And in every year, around 1 patient is included in the chronic sufferer of the pain. In this part of the world, low and middle income countries, the disease burden is, as a pain is sufficiently 18% of the populations. But what will be the burden of the post-COVID scenario? We don't know. We are not going to look up at this scenario. Are we ready to the another epidemics after the COVID? And we must be prepared for that. The post-COVID pain and disability may be the next epidemic scenario after this pandemic. So, in conclusions, what we can do that? We can identify the risk factors, as well as we can characterize the post-COVID pain intensity, onset, and durations. Not only that, we might change our medications and intervention techniques. We might plan for the rehabilitation and psychological evaluation and psychological support for the post-COVID warrior. But not the least, we should prepare our health infrastructure with the proper training and necessary preparation. And to do this all, we must have the research, we must have evidence. We should prepare the policy, and this policy should be cause the advocate to all the stakeholders, including the politicians, the lawmakers, the states, and the sufferer, the long hauler populations. So at the end, what we can do that? We can make a post-COVID-19 pain and disability consensus group. At the end, I must thanks to the organizers, the IASP, the champion of pain campaigner in the world. Thank you, IASP, for giving me the opportunity. Thank you all for your precious sharing. Thanks.
Hello, my name is Lisa Mccorkle. I am a team lead and patient researcher at Patient-Led Research Collaborative, and I'm a long COVID patient who became sick on March 14th, 2020. I'm going to talk with you today about who Patient-Led Research Collaborative is, some of our research results, a discussion of the value and challenges of patient-involved research, and where we need to go next. So first, who are we? Patient-Led Research Collaborative is a group of long COVID patients who formed out of Body Politics COVID-19 support group on Slack in April of 2020. Most of us got COVID in March of last year, and we all joined the support group after not recovering from our initially mild cases of COVID. In the Slack support group, we saw that there was a wealth of information being shared of patient symptoms, of different treatments they were trying, of the progression of their illness, of doctors and loved ones not believing them, and a group of us who had backgrounds in various areas of research, including policy, participatory design, neuroscience, data collection. We created a survey to aggregate all of this data, and after receiving 640 responses, and after only 9 days of analysis, we produced the first report on long COVID. Our first report brought to light the multisystemic nature of COVID and proved that there is a subset of COVID patients who experience these prolonged symptoms. We documented many symptoms that were outside of the list that the WHO and CDC were listing, particularly many neurological symptoms. Patients who had previously felt completely isolated and gaslit felt like this report validated their experience, and it led to us being connected to many MECFS groups and helping to start the conversation about long COVID by being featured in articles and medical journals. But we realized that our first survey was not enough. As we ourselves continued to experience symptoms, so did our community. We received IRB approval through University College London, since one of our team leads, Athena, is a neuroscientist there. And we put together a second survey, offering it in 9 different languages. It was fairly long and comprehensive. On average, it took about 70 minutes to complete, which is a long time for anyone to fill out a survey, much less people who are experiencing cognitive dysfunction and post-exertional malaise. So we made sure to choose our questions very methodically based on what we were hearing mattered to patients, what we were experiencing ourselves, and what we were hearing from patients with similar illnesses. And we didn't collect data just for data collection's sake. We inserted breaks throughout the survey to remind respondents to stop, rest, and pace, and patients could come back and finish the survey at a later time. With this survey, we received over 6,800 respondents from 84 countries. We issued a preprint in December of analysis on a subset of these patients, and it was published in the Lancet's eClinical Medicine in July of 2021. For this paper, we limited analysis to what we call first waivers, or those who got sick before June of 2020. We define long COVID as experiencing symptoms from a confirmed or suspected case of COVID for over 28 days, so we limited analysis to people who fit within that criteria. The vast majority of our respondents were not hospitalized, and our results, as you can see on the screen from the demographics, are not necessarily representative of the long COVID population, but our results are very telling of what long COVID can look like. We collected data on 205 symptoms, and we organized these by 10 organ systems, with neurological symptoms being put into smaller subsections because of their large number. Sensory motor symptoms were the most common neurological symptom, with 91.4% of patients experiencing a sensory motor symptom. Systemic symptoms, which include fatigue, post-exertional malaise, and fever, were the most common, with 99.7% of respondents experiencing at least one. The most prevalent symptoms at any point in a patient's illness were fatigue, post-exertional malaise, and cognitive dysfunction. You can see that shortness of breath, poor attention or concentration, and tightness of chest followed those. And at month 6 of illness, the most prevalent symptoms are almost entirely systemic and neurological, with the top 3 continuing to be fatigue, post-exertional malaise, and cognitive dysfunction or brain fog, followed by sensory motor symptoms, headaches, memory issues, insomnia, and heart palpitations. The impact that cognitive dysfunction and memory issues have on patients' ability to go about their daily life is really tremendous. 86.2% of patients felt their symptoms made them unable to work. 85.3% felt unable to make serious decisions. 74.8% felt unable to communicate their thoughts and needs. 68.3% felt unable to have conversations with others. 62.5% felt unable to maintain their medication schedule. 54.4% felt unable to follow simple instructions. And over half, 53.2%, felt unable to drive. An important finding that we came across is that there's no difference in memory, cognitive dysfunction, or their impacts by age. So these were just as common in 18 to 29-year-olds as they are for people over 60. Here are some quotes from patients describing these symptoms. I'll read a few of them. Mother has started to help me take the medications I'm on because I can't remember if I've taken them immediately after having the bottle in my hand. I was trying to fill out a mortgage application form and couldn't remember our rent. I put $37.50 a month. My partner said, no, it's $13.75. So I put $13,750. My partner said no, so I tried several more times. I was just guessing numbers. I put food on the gas stove and walked away for over an hour, only noticing when they were smoking or burning. I felt lost driving and had to stop and find my position in a GPS to be able to drive back home. It's a route I've done hundreds of times. I've had to terminate many phone calls because I could no longer comprehend the speakers nor communicate clearly with them. These are examples of what long COVID can look like, and specifically what cognitive dysfunction and what brain fog within long COVID looks like. A key feature of long COVID is relapses, where symptoms come back, usually after a specific trigger. Only a small percentage of patients do not experience these relapses, most of them do to some extent. And patients identified their triggers within our survey. The most common was physical activity, stress, exercise, and mental activity. 20% of patients had changes in sensitivity to medication. 12.1% had heightened reactions to old allergies, and there were new allergies and new anaphylaxis reactions, which could point to something like mast cell activation syndrome. Reactivations of other viruses, old viruses within the body, were also reported. Other serious, though less common symptoms included vision loss, hearing loss, facial paralysis, and suicidality. Menstruation was one of the triggers of symptoms in the previous slide, and we also saw quite a bit of menstrual changes. In fact, over a quarter of people who menstruate had abnormal periods, and 15% of men and 8% of women experienced sexual dysfunction. We compared those who tested positive and those who were untested or tested negative for COVID, and the only statistically significant difference in symptom time course that we found out of 205 symptoms was loss of taste and smell. In fact, the main difference between these two cohorts is when they were tested, with those testing positive getting tested at 6 days into their illness versus 43 days for those who tested negative. This makes it very clear that we should not be relying on a positive test for proof of someone having COVID and developing long COVID. So now that you've heard a little summary of a few symptoms of long COVID, it probably comes at no surprise that there are significant impacts on people's ability to work. In fact, over 2/3 of respondents either had to reduce their work schedule or were not working at all at the time of the survey. Accommodations like telework and flex time did allow many people to continue working, but those were not accessible to everyone. We heard from many patients who are having trouble getting on disability, and overall, it was a common sentiment that many patients found it difficult to financially sustain themselves. We have many more findings, but I will let you read those in our article that's published in eClinical Medicine. For now, I want to move towards the impact that our work as PLRC has had. Because of our research and advocacy, we've had a lot of opportunities, and largely it was because of this perfect storm of timing and history. Between 10 to 30% of people who get COVID will develop long COVID. This really is a mass disabling event. And during times like these, people want answers quickly. In the absence of similar traditional medical-led research, our research became a key source of information for public officials and medical professionals. And because of the groundwork laid by HIV, ME/CFS, and many other activists, we had the historical knowledge, patient platform, and window of opportunity to have immense impact quickly. Some examples of our impact and involvement is listed on the screen. Much of this has been done in partnership with Body Politic and other long COVID advocacy organizations. Some highlights: we are in the top 0.1% of medRxiv preprints. We've informed guidance for multiple government agencies, and we've been consultants on future and current long COVID research studies outside of our own. Over the last year plus, we've experienced many challenges that come along with patient-led and patient-centric research, and we've also seen many, many benefits to it. We've learned that this kind of research lets us ask the right questions because we have an intimate understanding of the illness. I can't tell you how many times I've taken a survey where it was so clear that a patient was not involved in its design because I didn't even know how to answer the survey. None of the provided answers really matched my experience or what I was going through. That is part of the value that patients bring to research. The results of a patient-involved study are more accurate and true to a patient's experience, so it ends up having more accurate results. We investigate the issues that matter to patients, which then also result in solutions that work for patients. And not only do we ask the right questions, but we ask them earlier, and we can get them answered earlier than much traditional research is able to do. In designing our research, we also consider the needs of the population being researched, which a lot of medical-led research does not do. An example of that for us, as I mentioned earlier, was incorporating suggested break times for people taking our survey. Also, within our group, we each have different backgrounds and skills. We have a different lens we bring, which makes us really effective and holistic. And our motivation is our own health and the health of our community. We don't have any ulterior motives that could get in the way of making decisions that are good for our community. But there are a lot of challenges we've faced as well. This research and advocacy takes a lot of effort, and we are all living with ongoing disability. In fact, one of my worst relapses was after working too long on some long COVID advocacy work. But it's led to us establishing ground rules where we prioritize our health over all else and ensure that we are using our spoons of energy wisely. Another challenge we've come across is a lack of resources. Access to medical system records, diagnostic testing, labs, large population groups. Without those, it really limits the type of research that we can do on our own and questions that we can answer without partnering with a larger institution. And in regards to funding, our donations have mainly been funding our website and other operating costs, but we've had little funding to provide incentives to survey respondents or pay ourselves for our labor. And we truly are at risk of burnout. You wouldn't imagine a world where a PI of some massive university study wouldn't get paid, and yet our work is having the same, if not more, of an impact on long COVID research, and we do not have anywhere near that same level of funding. Developing some sort of organizational structure has also proved to be a bit challenging, given that we just started out a little over a year ago, as strangers on the internet, and we want to keep the group as non-hierarchical as possible. And of course, because we are outside of the normal research system, we will always have doubters and trolls who call our research Mickey Mouse science and try to dismiss us. And this leads me to the last point I have here, which is the reductionist view of the patient. Over the last year, as I've been immersed in this field, it has been very clear that there is an underlying belief in the medical community that patients need to stay in our lane, leave the research and medical care up to the quote unquote professionals. We're not seen as whole people, as people who have a history beyond their medical history, as people with rich backgrounds, incredible skills, and valuable experiences that we bring with us before even considering that we have the lived experience of having an illness. And I really encourage everyone listening to look within themselves and think about if they have that same reaction, that most patients are just patients. They have an illness and that's it. Think through what are the ways our ableist and elitist society have influenced the way that we perceive patients. We are multidimensional beings, just like you, and we deserve to be partners in the research and care of solving what is going on in our bodies. Reducing us to just patients is doing a disservice to the future of medicine. So where do we go from here? Well, as research into long COVID continues, we really need to build off and pay attention to prior post-viral illness research. While illnesses like ME/CFS, dysautonomia, and many other post-viral illnesses have largely been ignored and gaslit, we do have some findings, and let's not reinvent the wheel. This is particularly important when considering treatments. We know that graded exercise is harmful to patients who experience post-exertional malaise, and that pacing is key. We also need research that samples from actual long COVID patients. For example, many or most patients who have long COVID were not hospitalized. Many didn't experience respiratory symptoms. Many had a mild acute case. And many were never on oxygen or even had low oxygen levels. And of course, something that I spoke about earlier is that many long COVID patients did not have access to testing and do not have a positive PCR or antibody COVID test. None of those things should be limiting access to care or being involved in a research study. And we also need to make sure that all of those patients are involved in research and that we are making sure that research is representative of the long COVID population. And finally, if you're a researcher, it's very important moving forward that you involve patients in every single aspect of your research from start to finish. Often what we see is that research that does include patients invites them to one meeting where patients are missing a lot of context. Researchers have been meeting for months, if not years already, and have a large part of the research already planned. That really limits the insights that patients can provide and how much influence they can have on the study. So start with patients and have a representative group of patients. View us as whole people with rich insights, relevant backgrounds, and skills. Don't reduce us to just a patient. And pay us. Our time is valuable. Our thoughts are valuable. We should be compensated. And providing compensation will reduce barriers for low-income communities and communities of color who have historically been either excluded from providing these kinds of insights or exploited for these insights. That's all I have for you. Thank you so much for listening. Please visit our website for more information about us, or feel free to email me at lisa@patientledresearch.com.
Welcome back.
So we are back. And
thank you so much for your rapt attention to the last three speakers. I believe Xavier has an update to share with the audience.
I will try to share the screen. Can you see it?
yeah.
Okay. So this study was published just 2 days ago in PLOS Medicine. This is a very large study with more than 200,000 people diagnosed with COVID-19. And using electronic health records, the authors look for long COVID features 6 months after the diagnosis. and they compared long COVID features with deaths after influenza virus. And as you can see, the mean age was 46 years old, with a bit more female, 55%. The matched cohorts between COVID and influenza can be seen on the on the third and fourth column. And I have highlighted for headaches, 5% of COVID-19 patients had still persistent headache 3 to 6 months after diagnosis. But there is a major limit. It's based on electronic health records, and patients were not specifically asked for their symptoms. So this is only patients that have asked for a consultation specifically for these symptoms. So symptoms are probably very underestimated. As you can see, also for fatigue or anxiety, the symptoms are very prevalent in patients-led cohorts, but it's only 15% for anxiety and 6% for fatigue in this cohort. So that can be very interesting to look for this new data, but it's also important to look for the limits of such data. And there is also this figure to look for correlation between symptoms. And headaches are not really correlated with other symptoms. Headaches and myalgia or headaches and other pain are not very related one to each other. So I think that there was one question concerning the link between fibromyalgia and headache. In this cohort, there is no clear relationship that can be found, but maybe data from the patient-led cohorts are more informative for such parameters. I will stop sharing, giving back. For the next questions.
Thank you very much, Xavier. Daniel, would you like to lead questions?
Yeah, we'll just stay in this line, and please, Lisa, if you have information on these questions related to patients' experiences and data, feel free to come in. But I think Xavier could help us answer this one. It's what is the place for CGRP inhibitors in the treatment of post-COVID headaches, especially when the headaches continue for more than 5 months?
There is absolutely no data concerning anti-CGRP antibodies and COVID-19 headaches. So it's very difficult to answer this question. But for patients with migraine-like headaches, it can be a good thing to try to use these treatments when they are available. That's not the case in France.
Yeah. Have you, in your personal experience, seen patients who had chronic migraine, who developed chronic medication overuse headache after COVID, and you by chance treated them as having medication overuse headache and improved? How frequent this situation was in France or your experiences?
I see patients with chronic headaches almost daily, but I have seen only 2 or 3 patients that had an exacerbation of their headaches after the COVID, and only for 6 to 8 weeks in all the cases. So that was not really the problem for patients with previous headaches to develop a more severe course of headaches. It's mostly patients with new daily headaches that are the problem now.
Okay. There's one here for Lisa. Congratulations, Lisa, excellent initiative and super good job. Only one question: how many patients with long COVID and suffering from cognitive and memory problems were in intensive care?
Sure, thank you. So from our cohort, most of our patients were not hospitalized at all. So 92% of our cohort was not hospitalized. And that includes the ones that were hospitalized were split between going in ICU and not. And within our entire cohort, about 88% experienced cognitive dysfunction. So we haven't done the analysis to see of the hospitalized patients, what percentage are experiencing cognitive dysfunction. But it's not, our cohort isn't representative of the long COVID population, but it's very clear that a very large proportion of long COVID patients are not hospitalized at all. And cognitive dysfunction really is one of the more prevalent symptoms that we see.
Okay. Good. So fourth question. Does the current evidence suggest potential link between Ndph and increased risk of migraines?
I think it's also for me, as for new daily persistent headache, it's mostly like tension type headaches and not migraine. So I think that the link is between tension type and new daily persistent headache more than migraine.
Okay. Very interesting. Lisa, it's interesting. I liked very much the part of your, I would like to make a comment and maybe open for discussion also. When you talked about the way healthcare providers see patients sometimes and how stigmatizing can be, it's very interesting when we read, for example, the Global Burden of Disease published a few years ago, assessing the prevalence of all diseases worldwide. And when we read in the first lines of the findings that only about 4% of the human population is free of symptoms of any disease. So it's interesting to think that maybe 96% of people have some type of disease. We are all patients. We just either don't know it or are just waiting to find out. And it raises the question, a statistical question, is it normal not to have a disease? I'm kidding, but it's not normal. It's out of the standard deviation. So I find it very interesting the way you put it.
Yes, but during the COVID, Daniel, after the COVID, we can make it in the disease burden for the post-COVID patients. So might be more than that. So on in 10 patients or 18 patients of this part of the world, maybe it will be raised. A lot of patients is there. So the Lisa can do some research, patient-centered research, and the region and geographical part also.
And that's a very good point. The idea
yes.
that the entire world is grappling with a disorder that is going to change them permanently going forward is going to change what an average healthy person looks like. And many of our scales are scaled to old ways of how people were. And we may even find ourselves having to reevaluate what average is on the scales that we have. I see there is a sixth. Another question here.
This part of the world is they are taking care only the acute phase of the disease to reduce the burden of the disease, like the mortality and morbidity. But the rest of the things, the post-COVID part is mostly neglected. So it may be the area of the research of the next era.
All right. Well, there's another question here. I think a good one for everybody to take a stab at. Could the higher incidence in gender reported in certain symptoms be related to cultural differences or societal norms? The questionnaire adds, it was interesting to see that data from China, where fewer males reported headaches as part of their long COVID history. From South Africa, and sometimes pain scores can be influenced by social and cultural views on pain. What do people think about those kinds of dimensions, the way that the time of the pandemic unfolding, the different places in the world where it is happening? How is that going to influence the long COVID picture?
Yeah, I think, from my perspective and what I've seen, I definitely think that societal and cultural norms play a big part in who is reporting symptoms and how they report symptoms. But I also think it's important, especially with gender differences, to understand that there may be something physiological at play, and that there may be a reason that more women are reporting certain symptoms, and it could have to do with their biology. And I think too often I've seen, a huge symptom that we see is that folks with long COVID experience menstrual changes or experience severe symptoms around their period. And that is often not asked by researchers. It's something that is often kind of looked over. But that it has a huge impact on people's lives and maybe a big clue into what's going on and how long COVID is presenting itself. So I definitely think there are some, cultural and societal differences there. But also I think there's some, biological things going on that may give us some good clues.
If one were to look at some of the prior literature to help us understand that, which Lisa brought up, there was a study done with the National Health Interview Survey in 2016 looking at fibromyalgia. And when they looked at sort of the doctor-physician reported fibromyalgia versus people who had the symptoms of fibromyalgia that would have met the 2016 criteria, it's found that 2% of the population had a diagnosis and 2% of the population would meet criteria, but only a quarter of them were the same people. Right? When you looked at those carrying a diagnosis, the gender differential was about 9 women to each man. When we looked at actual symptoms, it was about 3 women to each man. Right? And so I find that to be a useful metric to think about what the contribution of physiology might be, which would probably be closer to 3 to 1, and what the culture and society may be influencing, which is that additional factor. Just an interesting way to think about it. Is it possible to infer that cultural factors may affect reporting of post-COVID pain syndromes worldwide? That was a follow-up question. Anyone want to take a stab at that?
Yes, it's maybe the same like that. The cultural and social conditions is affecting the patient's perceptions and even their rights to the for making the treatment options. That's why the people they are underreported in the low and middle income groups. Then it's higher in the first role. So cultural and financial and economic is a challenge for diagnosis of disease and even the management and the protocols.
I have a question for the audience, for the group here. We've talked about culture and gender's effects, but how about just the pandemic itself? Is there any possibility that earlier in the pandemic, either due to strain or due to the ambiguities of COVID and the panic of the times, versus later in the pandemic, do you think that the timing that one got COVID in all of this may affect long haul outcomes?
Probably to some extent, the first speaker is giving the clue that the COVID initially it is thought that the disease of the death and disease of the uncertainty, but the complications is like almost same in the like in the 130 years back in the influenza pandemic. So like it is as simple as the headache. The headache is at that time it was reported as 6%, and now it is around 5 to 6%. So propaganda and the medias and to some extent is influencing the pattern and even some reporting the disease.
So you think that would be an up bias or a down bias over time?
Yes, yeah.
You think it'd be an up bias over time? How about long haul in sort of breakthrough cases? Do we think that with vaccines being rolled out, that long haul will be different in people who get COVID after vaccination than it would be in the unvaccinated? It's a sort of open question there.
Yeah.
So the patient-led initiative is attracting a lot of questions. We'll continue, Lisa. So 2 questions in the same line, and you can expand if you want to address other issues. Thanks for the presentation, Lisa. Were there patients who observed a worsening of prior pre-existing neurological disorders in your study? And in regards to the patient-led research initiative, is there ongoing longitudinal follow-up studies to understand the trajectory of symptoms burden?
Sure, thank you for those. So we actually didn't see a ton of like the pre-existing conditions within our group were not abnormal compared to the average population. So we didn't necessarily see that any pre-existing condition was more likely to occur within the cohort. There's a hypothesis that's being thrown amongst the patients that long COVID may be, for a lot of patients, an exacerbation of a previously unknown neurological disorder or other pre-existing condition. I think that hypothesis has a lot of weight to it. But no, we haven't seen too much of like a worsening, with the exception of folks who have ME/CFS, or any of the illnesses that people with long COVID are often getting diagnosed with. They had it before getting COVID, those symptoms are getting much worse usually. So we have been seeing that. In regards to Brian's earlier question on the vaccine, we have not done research on this. This is just based off what we're hearing from patients. We are seeing the symptoms do look fairly similar to both post-vaccination long COVID and pre-vaccination long COVID. But that's very, that's just based off anecdote. So can't say too much about that. And in terms of longitudinal follow-up studies, so the survey that all of most of our research was based off of, it continues to be open. So anyone can go in and update their survey responses. We can gather additional survey responses at any time. So we're hoping, maybe that's a possibility. It's really based off of if we have the capacity to do that. Right now, what we're working on is we did a vaccine survey to see if patients with long COVID, if their symptoms improve, do not improve, get a lot worse after vaccine. And so we're seeing very initial analysis that, and I'm sure most clinicians have also seen this in their practice, that we really see the wide spectrum. There are some folks who are, their symptoms have completely gone away. But on the other side, there's some folks whose symptoms have gotten a lot worse from the vaccine. So really unclear, but we're doing analysis on that now, and hopefully we'll have results on that soon.
There was some recent work out of the UK looking at for breakthrough cases, looking at the complications after breakthrough cases in the vaccinated and the unvaccinated. And it does look like the vaccinated are not having as frequent symptoms as the unvaccinated colleagues. And so I take that as a good sign that vaccination may help prevent long COVID kinds of complications, and sort of suggest a little bit about causality too.
Lisa, just a brief comment. We know that the basis for listening to the patient and individualizing the assessment is specifically to look at every specific particularity of each patient. But as a whole, and I know patients with post-COVID syndrome, they are heterogeneous by definition in every setting, every time we look at them. But would you have a core group of symptoms that are more frequently reported by patients, or a top 5 or a top 10 hit of symptoms coming from this cohort that you have?
Yeah, so
you mentioned.
Go ahead.
No, you mentioned the menstrual oscillations and symptoms, which is extremely interesting. I confess, in a normal neurological consultation, except for headaches, we don't usually question patients if other symptoms might fluctuate with menses. And it's very insightful. I was wondering if you have other core symptoms, and it would be really interesting to maybe have this checklist sometimes to try to guide us when assessing patients.
Yeah, absolutely. So, I mean, our top 3 symptoms that we see are post-exertional malaise, which is symptom exacerbation after any exertion, fatigue, and cognitive dysfunction. Those are the most prevalent. We have a list, in addition to the journal article in eClinical Medicine, we have a list of the most prevalent symptoms on our website, which is patientledresearch.com. So please feel free to go there. I think it's a really comprehensive list of symptoms that people with long COVID experience. So it would be a great place to go to if you're creating a survey yourself or asking patients about symptoms. I think one of the things with the, particularly with the menstrual changes, is that often it may not even be that someone's cycle has changed, but it could be that people are experiencing worse symptoms either before, during, or right after their period, or at different places within their cycle. And so I think that's something that is hard to, not a lot of people even maybe realize that about themselves, and having a clinician ask them, like, what triggers worse symptoms, and have you figured out where in the month things get worse, or what types of things trigger it, could be a really important question to ask.
Great. Very well. So would you guys have any other comments that would like to share with us? No? So maybe we could start the closing words, Ryan.
Well, we thank you all for taking the time to be with us today. We hope that the conference was helpful and educational about all the complications that we can be expecting to follow the COVID pandemic, and the things to be mindful of in terms of patient care, self-care, and how we should be conducting the research that will provide insight into what we should be doing down the road. Any other comments from you, Dan?
No, I'd like to thank specifically also the ISP COVID task force for supporting us and bringing together all these the board members. So thank you all for participating, for your time, and also thank the listeners. And this material will be online for a while. There will be some avatar-based translations to other languages, which is something it's pretty much new for most of us. Let's see how it's coming up. So I hope that we can continue learning and exchanging, probably maybe do an update next year and have more information on this.